I like your background.
Mine is natural.
You're natural. Mine is not natural. I am not standing in the middle of Valley Children's lawn.
I know. I know you're not there.
Well, thank you. Thank you so much for joining us for the afternoon session. Again, these sessions are going to be recorded, so people who are not able to make it to this session will have access to it at a later time. So I want to go ahead and introduce you, Dr. Santos, if you don't mind. Dr. Santos has been with Valley Children since 2016 and is our medical director for pediatric neurology. And he's also our epileptologist. He has really helped build our program from the ground up and has helped the hospital get us to where we're at with a level 4 accredited epilepsy monitoring center and a surgery site for epilepsy surgeries. So we're really grateful for all of the groundwork that he's laid for us and continues to advocate and educate for our families. And so I'm going to hand it over to Dr. Santos, who's going to be able to talk to us today about the importance of EEGs, and we'll answer any questions that you all have. So thank you so much.
Thanks, Kate. Thanks for that introduction. I really don't have any formal slides to share with you because I would like to open this, make this as an open forum, trying to learn or discuss whatever questions you might have related to EEG. Why do we do EEG? What kind of information we're looking at? Where do we go once your child has had an EEG? When do you need a follow-up, and so on and so forth. So I'll open it to everyone.
I'll start. So I guess really just for maybe some people who aren't 100% familiar with what an EEG is and what the purpose is, can you give us a little bit of a background as to where we start? Say our kiddo is displaying some maybe abnormal movements or behavior and they're talking to their pediatrician. Where do we go from there? What does that look like for your typical family?
Well, obviously, when you talk about patients who may be having seizures, we start, and the most common term that we use is seizure-like activity. The only reason why we call it that is because that could be coded on formally on ICD-10 ENM code. So if you talk to your pediatrician and you say, hey, listen, I've been noticing these things that's happening to my kid, and obviously the pediatrician says, well, tell me about the events. Sometime the information may be sufficient enough to say, I think you're having seizures. Or, you know what, I don't know. But it would be nice if we could, one, either send you to the neurologist, or two, maybe I could send you for an EEG before I send you to the neurologist, or do it as a sequential thing. So EEG is the only test we have available to date when we are talking about a kid who possibly is having seizures. One thing you need to remember, though, is it's not a perfect test. So I will start there. Even in patients who we know are having seizures, depending on the day, for example, you may be able to see an abnormality on an EEG 50% of the time if you are doing the first EEG. With exceptions. A good exception is a patient who is having absence. To me, in my experience, if a patient is having absence epilepsy or having absence seizures, if they are not on any medication, their EEG, the first one, should be abnormal. So yes, there are exceptions, but in general, the positivity rate of the first EEG is 50%. So there is reason to say, okay, you had an EEG 2-3 months ago, I'm going to get another one. And you might say, why? Because your number goes up from 50, and you could get to up to 90% if you get 3 EEGs, right? So it's never a perfect test. You cannot get 100%. EEG or seizure really diagnosis is really dependent on your history taking. Your EEG is just a supplement to that. It may tell you, oh, your initial impression was wrong because the EEG looks like this. or you may have a child where the EEG looks different than what you expected based on the history that they provided. So you have to put the two together. But at the end of the day, it's what the parent or what the patient is doing that you have to treat, not the EEG. I guess
Okay.
questions are coming. I saw one, then it disappeared, and then there's one there. Can you elaborate between a routine EEG and a video EEG? Is that?
Yeah, so can you give a distinction between, what a routine EEG is, what an ambulatory EEG is, an EMU mission, and kind of what does that protocol look like even to get an EEG?
Okay. So a routine EEG is just your, okay, I'm going to send a kid to the EEG lab. They hook the kid up, and we try to get a sleep and awake segment, and it lasts maybe 30, 40 minutes, over an hour if it's a baby. By including the hookup, you're in the EEG lab maybe an hour, hour 15, hour and a half. So this is as routine as it gets, right? So you just go in there, and if you're having events and they are frequent, or if your question is absence, then we could do something during the EEG to say, yep, your kid is having absence seizure. But if you are trying, if it's negative, I said earlier that the sensitivities of the first one is 50%. So you're really not supposed to rely on what you see on the EEG to answer the question, is that a seizure? And if so, is that something I need to treat? So if you wanted to increase the sensitivity, then you go for a longer one. A longer one would be a typical video EEG admission to the EMU, 24 hours, 36, 96 hours. If you're having spells that are infrequent, we would rather you come to the EMU for a longer term. If your spells are happening every day, maybe all we need is a 24 hours or 6-hour EEG. The difference between ambulatory and an admission EEG is really the location. But what's more important is the quality. Maybe it's not going to be as good as an EEG done in the lab. If I start scratching, 1 or 2 electrodes could fall off, and then you press the button and say, my child had 1 and 3 or 4 electrodes are not connected, it's not going to help me read that EEG. So I may miss a very important spell or event during an ambulatory recording because the technical quality is not well maintained, as it would be if you are in the EMU, because always someone is watching you. So that's the difference between the two, or the three, I should say.
So I know it's not really related to maybe specifically an EEG, but I know that what we always ask our families and our patients is to get, a video recording of any type of seizure-like activity that you're noticing. Does that necessarily take the place of an EEG, or are you still going to want to do an EEG, even if a parent has a clear recording maybe of what's going on? What are your thoughts on that?
Well, yes and no, right? Say, for example, I'm going to go back to a kid who's having staring episodes lasting 20 seconds. They're doing something, they stare, they blink their eyes, and their head may move with the blink, and then they're back to normal, like nothing happened, right? I could do an exam in the clinic when I think the kid is having absence, just hyperventilate the kid, and if the kid is having absence, more often than not, they're going to have one. So in that case, do I need an EEG before I start the kid on any medication? No. I could treat that kid and say you're having absence. Some people would say, okay, I know you're having absence, but I'm going to send you for an EEG. I'd like to have a baseline. Okay, so it becomes a personal decision at that point, right? If I have enough clinical information, I'm convinced your kid is having seizure, then whatever the EEG shows is an additional information to what I already made. if a child is having absence, I mean, partial seizures, but I'm not sure, or it looks like a partial seizure, I'm not sure, or I'm almost sure, I always get an EEG and say, okay, I think your child is having absence. I'm going to start you on medication, especially if it's very frequent, because it may take a month or two before we get the EEG, and then we'll talk after the EEG and see where we are. The other instance would be you're treating a child, right? I know you're having blah blah blah, or let's go back to absence, and I put you on absence medication, and it doesn't seem to work. And then the pattern of the event changes. Then you say, well, maybe I have this wrong, right? Let's get an EEG. The other reason why we would do a periodic EEG in IC1 is it's not really periodic, but when a kid has been seizure-free 2 years, and we are talking about the possibility of coming off medication, that's one of the things I do. I look at an EEG before I say, okay, it's okay to stop the medicine or taper the medication. Or no, your EEG is still very abnormal. I don't think we can do. Requesting a periodic EEG is not something we do. There are only maybe 1 or 2 instances where we would do that. For example, a kid who's having infantile spasm, and we diagnosed, we start the treatment. In 2 weeks, you need to come back to get another EEG. And then we may or may start you on a different medication, and at the end of that treatment, I say, I need to see another EEG. Because what you do in that instance is dictated by what you see on the EEG. So other than that, there is really no such thing as getting periodic or regular EEGs.
How often, like other than the periodic one that the doctors are making a decision, hey, we need one for this reason, how often do you typically suggest to our families and to the patients on receiving EEG? Is it like once a year? Is it if symptoms change? What does that look like for our
so there is
family?
no such no such protocol. It's on a case-by-case basis. For example, if I know you're having seizures, I've had an EEG, and let's say it's normal. It was the first EEG, but I know you're having partial seizures. I put you on a partial medication. I titrated your partial medication to where I think it should work, yet you're still having events. I may get another EEG, say, well, I may be missing something here. Or I could just say, okay, this is not a medication for you, because not everyone responds to the first medication you choose, right? The best response you're going to get with the first medicine is 46, 47%. So you have to go and choose a second one. And then let's say you choose a second one and you did the same thing, you maximize, and you should expect an improvement in the seizures, and you don't see anything, then you say, okay, let's get another EEG. Or, and say, well, we have not made a dent on your events. Maybe my diagnosis is wrong. I need to bring you to the EMU and do a long-term EEG, and hopefully capture one of the typical events. So having said that, one of the things that a parent could do when they are questioning whether their child is having seizure or not is, in this day and age, so it's every phone has a video. So if you could video a few events and get that ready before you even come to the primary care, that's going to be very helpful. Because it really, you cannot do a better description of the EEG than what we see on the video, right? I know it's hard. I know it's scary when your child is having seizures. So I don't want you to just say, okay, Dr. Santos told me to get a video and not pay attention to the child. You have to do the what we call the seizure protocol first, of precaution. And once you've done that, and you may have someone else with you in the house, then you could say, can you turn on your video, please, and see. And you could tell the school teachers the same thing. So because what they see at school may be different than what you see at home.
Well, and oftentimes when you're in the heat of the moment of what's going on,
Oh,
right,
yeah,
our
I know.
perception is so different on what is actually happening.
Correct.
Because as a parent, we just jump in and we want to do what we're required to do. But then when asked to later recall that, we know that our recall as parents isn't going to be as detailed as maybe the video would be. So that would be
Yes.
something,
So a good example are the partial seizures, right? So I may be having a partial seizure and then I just stop. And then I start turning my head to one side. And that would be the first thing that the parent would see. But they didn't realize that the kid was having seizure 10, 20 seconds before already. So having a video, if it's like, for example, in the EMU, we could tell that the seizure actually started 10 seconds before the parents actually pick it up. So we could tell the parents, this is what the start of the seizure looks like. The other instance where the video would be helpful is some parents would say, I see two different kinds, right? One is the staring kind and one is the big one where they shake all over, right? But if you actually capture both, the big ones actually start with the staring episodes. It just spreads to the other side of the brain. So the kid is not really having two types per se, but two versions of the same thing, a partial seizure that never spread to the other side and a partial seizure that eventually spread to the other side. So it's a secondarily generalized partial seizure. So the treatment is the same.
would you suggest, Dr. Santos, I know it's not always possible, but would you suggest for families, if at all possible, to get an EEG prior to coming to their first neurology visit?
It will help. I mean, a good, that's really good, especially in the area where we practice, right? We have patients coming from Sacramento all the way down to Bakersfield. And if you see them without the EEG and then you tell them, I'm going to send you for an EEG, and then the first question they ask is, do I need to come back to get the EEG done? I mean, we try our best to get the EEG done when you come, but the EEGs we do on a daily basis are pre-scheduled, so most of the time it's full. So it does help us a lot if you could get an EEG before coming to your first appointment. In that way, you know, I could discuss with you, or we could discuss with you the result of the EEG. Supposed to having one visit, we schedule the EEG, and then I call you. If it's abnormal, I'll bring you again. So that's really 3 visits altogether, one for the EEG and 2 for follow-up. So if we could, not that we don't want to see you, but if you're traveling 3 or 4 hours away, that's kind of difficult. And then transportation issues, right?
Perfect. It looks like a question we have is, would you request an EEG if you're titrating medication?
Not routinely, no.
Okay.
Meaning
And
titrating, you know what you're treating and you're convinced that what you're treating, let's say, is a partial seizure. No.
okay.
At
And
the
another
same
question.
time, we tell parents, you know, you call me in 2 weeks, and you say, why 2 weeks? Because it takes 2 weeks before your body actually get to see in your system a stable dose of seizure medication. So it may not work necessarily the first week or 2.
So
So no,
it's
we don't
important when you put on
titrate on each.
so it's important when you put on your paperwork when you leave to please follow up in 2 weeks to call us, because we definitely want to
Yeah,
make
right.
sure, you know, that we're keeping track of what's going on. If something should happen, you know, the 2 weeks is a really important time period to pay attention to.
Yeah, I always tell parents when they need to call me first.
Perfect. Another question that came through is, can a child speak through an absence seizure, or the absence seizure is that small?
Yes, so I just saw one kid today, may not read an EEG. So if you are not actually recording the EEG at the same time you're testing the child, meaning questioning them, asking them questions, during the time that they are actually having the absence, which for this kid was lasting 5 seconds. So 1001, 1002, it's so short. So by the time, even for them, when you see the abnormality on the EEG that tells you that the kid is having absence, and you start asking questions, they may be towards the end, and then they may answer your question. So it doesn't mean that they were talking during. So strictly, when a child is having absence, they are unresponsive during the time. But as soon as that EEG abnormality stops, they start talking like nothing happened. That's why it's so hard to pick up. So if they're counting 10, 9, 8, 7, 6, 5, that pause really just represented the seizure. So if you're at home, you may actually think that they're still having seizure because you talk to them and they're responding, but in true sense of the matter, the seizure actually is over. Now, if they're having multiple events, they may actually have what we call a post-ictal state. They may be confused and sleepy, even if they're having one absence after another.
Can you explain a little bit to us why it's so important to capture an EEG, for example, in different states, like when a kiddo is alert, when they're sleepy? What's the reason that we ask our children to come in for an EEG, for example, an outpatient EEG, sleep deprived? What purpose does that serve?
Yes, so that's a very good question, Caitlin. We actually would we often tell parents to try to sleep deprive their child the night before they come. And there is reason for that. And if you're going to sleep deprive your child the night before, you shouldn't let them sleep on the drive over. They could sleep during the EEG. The EEG that's taken during awake only is not as informative as an EEG that's taken with sleep. Meaning, if you're going to see an abnormality on the EEG, you're more likely to see it when the child is asleep. So if a normal EEG that's taken during awake and sleep, or if an EEG is normal and you have awake and sleep segment in there, it weighs a whole lot more than a normal EEG with only awake segment. Okay, so it's more sensitive if you get a sleep segment. There are patients where the abnormality only on EEG, you only see when they sleep. Or you may see 1 or 2 when they're awake, and then 10 per page when they go to sleep.
How much? I just know that we have families that come into the hospital, right, for their EEG, and they follow directions. And then, like you said, their kiddo does fall asleep on the way here. It's a 2-hour drive, from Bakersfield. How much sleep deprivation do they need on average for you to get a good picture of possibly, what we're looking at?
It's not much as to how much sleep deprivation. I mean, obviously, if you're in the hospital and we're trying to capture or precipitate an event, one of the things we do is try to not let them sleep, right? So the more sleep deprivation, the more likely for you to capture an event. At home, when you're just trying to get a sleep segment on the EEG, and I mean, you have kids, Caitlin, you know how hard it is to keep someone awake at night, right? So I just tell parents, sleep deprived. I know it's hard, but try your best. But the key thing there is, if we're going to sleep deprive them, you could do one of two things. You could say, okay, hey guys, I know you scheduled me tomorrow. I have a 2-year-old who I'm going to try to sleep deprive. Can you put me on the first thing in the morning so I don't have to wait until 11 to keep my kid awake from the night before till 11 EEG? So you could request that. And the other thing I told you already is don't let them sleep before the EEG. You could let them sleep when they are on the recording. Or you could hold feeding and hold it for later until they're in the EEG lab and hookup is being done. And so the first record you see on the EEG is sleep. Then you could wake him up towards the end and see what the awake EEG looks like.
How much sleep do you need to capture typically on the EEG? Like, what's the average amount of time that you guys are looking at?
Again, not a specific. The only thing outside of that answer is when we're recording newborn babies, because in newborn babies we would like to capture what we call 3 states: awake, when they are in active sleep, and when they are in quiet sleep. So an EEG, a newborn EEG is not complete, technically not complete, unless you have all 3 of them.
Okay.
We're happy if you could show us a few minutes of EEG and sleep on the EEG.
Okay. I know another question that comes up quite often, and feel free anyone to put in the chat if you have any more questions. Another question that often comes up is, does my child, need to stay on their medication for their EEG? Is this something, I know it's per patient, but is that a question that you guys get or that you will typically give directions to families for?
Not in that way. The one common question they ask is, should we wait until we get the EEG before we start the medication? Or they say, well, the EEG is normal, but my kid was already on medication. What does that mean, right? So I mentioned earlier that the main decision point, or the main decision information that we get, is the history. If you have enough history that you could say your child is having seizure, we start the medication even before we'd get the EEG. EEG before starting the medication may be normal. Yes, the EEG may be normal while you're on medication, but you have made that decision based on the clinical information that's provided to you. So it's not going to change what you do. When you're titrating, that's another, not titrating, when you are seizure-free 2 years and you're getting a follow-up EEG before you start the taper, that's another common question. He's on medication. Yes, he's on medication, so the EEG may be normal, but it's nonetheless a good information. We could tell you, if we take you off medication, I'd rather see an EEG that's normal before we taper you off versus someone whose EEG is still abnormal.
Oh, so that's a good point. So if we are looking at maybe discontinuing some medication for a patient who's been seizure-free for 2 years, you then would like to see a normal EEG while they're on medication before even considering taking them off of the medication.
Well, yeah, because you're on medication and you get this thing that's still significantly abnormal, especially when they sleep, and you're like, I could still take you off, but the chance of you having a recurrence would be very high, right? There are exceptions to that. There are kids where, whether they're seizure-free 2 years or more, because of the known epilepsy syndrome, they cannot really come off medicine. Juvenile myoclonic epilepsy is a good example of that. So it's easy to control, but the bad part is you cannot come off medication. You're taking medication forever.
Any other questions, anyone?
This is a quiet group.
Well, I guess what is the number one most important thing that you want parents to know when discussing even the opportunity to get an EEG? What's something that, when talking to their pediatricians, because normally that's the first stop, like what should parents be looking for, and what kind of questions should they be asking their pediatrician?
Well, I think we partly mentioned this, right? So if you're wondering whether your kid is having seizure because they're having events, the best thing to do is really, one, get a good description of the event. If it happens at school, you talk to the school teacher and tell me what happens. And if it's happening frequently, you could ask yourself or someone in the house to help you video the event and even the school, and take that to the pediatrician and say, okay, I've been seeing this for the past 3 months. This is what I see. I have it on my phone. You want to look? And then the pediatrician may say, I don't think that's something you need to worry about, but you're still worried because you know what the seizure looks like. You have relatives, nieces, nephews who have epilepsy, and you say, can I see a pediatric neurologist, right? And then you could also say, okay, can before, since I travel too far, or whether you travel too far or not, can we get an EEG before I see the neurologist? So that's within your rights to request. I would rather see an EEG when you come see me the first time if the question is whether your child is having seizure, to one, avoid an extra visit, and two, because most of the time when the pediatrician requests an EEG, they really don't tell you the results. They say, oh, it's abnormal, and the neurologist will explain it to you. In the meantime, your appointment with the neurologist is in a month. So you've been biting your nail at home, knowing that the EEG is abnormal, but you do not know what that means. So if it's done before you come, then I could sit down with you and say, okay, this is the EEG is abnormal. This is what it means.
Exactly. And like we've talked about in earlier sessions today, no question is a silly question. And so, we're just advocating for parents to really reach out to their doctors and their pediatricians. And, if you're noticing something strange, you're typically the expert on your child of their behavior. And
Yes.
So just having that conversation and feeling supported and encouraged to talk about it and not ignoring it, I think is really important. I know that one parent put in here, Dr. Santos, any idea how to track absent seizures? They're so quick. Oftentimes I wonder if my child is daydreaming.
Yes, it's so hard. I wish I have a good answer for you on that one, Amparo. But that's why you will never see the first absence. When you see one, the kid has been having it for months. So there is a significant delay in the diagnosis. The kid who I mentioned earlier who had an EEG is 8 and she's been having episodes since age 3. Okay, so you're talking 5 years. So I guess just be vigilant, I guess. Most of the time, after a while, you could ask your kid if you actually saw them have one. You say, did you know you have one? A lot of the kids would actually tell you, yeah, mom, I know, I just had one. Because I know you were talking, and then all of a sudden I don't hear anything, and then I came out and you were talking about a totally different subject. And most kids would mention, I felt like someone pushed the pause button. I got stuck in one place, and or the teacher may be talking one thing, and then when I came out, he was talking about a totally different subject. I missed something. I know it's very hard, and like I said, I wish I could tell you how the best way to track it. But if you have an older child that you could rely or really ask them, what do you feel before or afterwards? You could ask them. You could ask them to really document how many seizures they're having. It becomes a team effort, but it's very hard. And then towards the end, daydreaming, because right, you diagnose them with absence. They look like daydreaming. You put them on medication, and now the parents are watching them like a hawk. So every time they step, they do that. They say, "Oh, you just had one. You just had one," and then you're like, it becomes a problem on our end because what? Is he still having seizure? Is the medication not working? Is the kid not taking the medication, and therefore he's having more seizures? And so we could do another EEG, for example. And when I think the kid should be doing well, and the parents keep on saying, Dr. Santos, I still keep seeing the staring episodes. I said, okay, fine. I'm going to bring you in. I want you to press the button whenever you see him stare. It's interesting to see that majority of the time, the staring episodes that the parents are so worried about on medication are actually not. So it's a very good information for us. It's a good information for the kid. It's a very good information for the parents and the school. Because it's hard.
And oftentimes, oftentimes it's our littler ones and, elementary school age that are kind of getting in trouble for not really paying attention. And so we hear, our parents will come into the clinic and will say, well, teacher just keeps saying that they're daydreaming and they're never on task. And, so there's a lot of different things that we have to tease apart for especially the absence seizures. But being able to have those conversations and even talk to the teacher, we advocate very much for our families to have an ongoing conversation with their teachers because they're there a significant portion of the day. And so just having those conversations and talking about it is really, really helpful, especially for us in the clinic side. Hearing some of what the teachers are saying, what you're seeing at home in different environments, it really plays a big part in us being able to help out.
So Amparo has a follow-up question. I asked, he says, no, mom, I was thinking I heard you, but he is staring off. Puberty is coming on. Can I request that test anytime? I'll answer the last question. Yes, you could request that test anytime. And if you are on medication, if your child is on medication already and you're wondering whether they're having seizures or not, I would recommend getting a longer one, maybe a day or two, right? The asking question and say, hey, I just saw you staring, you just had a seizure, and your child says, no, I don't. That conversation is so dependent on the age. In an adolescent, that's the most common answer you're going to get. Not because they don't want to talk to you, it's because they're embarrassed to tell you or for people to find out they're having seizures. Okay. So most of the time they're going to tell you, no, mom, I'm not. I heard you. So if you don't want to irritate your child any further and you could continue the conversation with your kid, then you could say, okay, what did I just say? Can you tell me what I just said or what we were talking about? So you're practically doing some tests. Or you see them stare, you could actually get close to their face and maybe do this to their eyes and see if they would blink, or at least you get a response. I know it's so quick, but if you're very alert and attentive, you could do that quickly and get yourself additional information. Say, yeah, he was out. I mean, puberty is when, especially boys, I guess, nothing against you guys, but we tend to stare and ignore, right? I do that a lot. That's my middle name. You're not paying attention to me again. Yeah, we do that a lot. It's an X chromosome. It's a Y chromosome thingy. I'm sorry, mom. And they get very upset when you bring this up to them. And you have to consider the fact that they're adolescent and now they have to deal with the fact that they're having seizures. It's very hard. And puberty is like pregnancy. You could have exacerbation of your epilepsy when you're entering puberty or during puberty. That's a fact.
How do we know, Dr. Santos? I mean, I know you guys will decide to increase the EEG time, but as a parent, what would you suggest, kind of some of the questions that they need to ask or some of the things they need to tell you in order to get a longer EEG or talk to you about, longer EEG? When do you decide as a provider or doctor, when's the best time and how long do they need to stay in order to capture what we're trying to capture?
Okay, so let's create a few scenarios. I'm convinced your child is having an absence. I put you on medication and the last EEG we did was normal. Or I saw you last week and I hyperventilated your kid for 3 minutes. By the way, you could precipitate an absence if they're not on medication or suboptimally treated when you hyperventilate them in the clinic. You ask them to breathe hard. We ask them to blow on a pinwheel. So I saw you last week. I hyperventilated you. I didn't see any seizures. So I was like, great, you're doing well. 3 weeks later, the parents are telling you they're seeing staring episodes. They're not sure. I'm not sure, doc, whether the kid is daydreaming or just not paying attention to me or he's just being a boy. I say, okay, how often do you think this is happening? Maybe once every 2 days. Okay, let's see if we could bring you in for 3-4 days. Oh, I see this every day. Okay, maybe 1 day of video EEG admission would be sufficient. I want you to press each time you see what you're concerned about. Another scenario would be a child with partial. And again, the parents are saying, I have not seen the ones that look like, or we decided they're seizures, but I'm seeing something different now. I wonder if they're seizures too. Well, next thing, how often are they happening? Then you decide, 1 day is good enough, 2 days, I think is what we need, or maybe even longer, right? So you listen to what the parents are telling you, or you could ask them question to help you decide what you need to do. But parents you have to listen to every parent. I mean, they're there 24/7. I never say never to a parent.
They're experts in their
They're
child.
expert. Yes, they are expert. So they're the one who see it.
Well, I think a good thing to note too, and that I think people forget to even question is, well, why do we need an adult to be present in the EMU to push the button when they think they're seeing a seizure? And I always like to tell families, it's just as much of an education moment for the family as it is for the kiddo who's having a seizure. Because like you said, sometimes the seizure is taking place way before anybody ever recognizes it, right? And so it's important that you can use that moment as a doctor to educate the family on, hey, this is what's been happening, and you wouldn't have been able to know this anyways, but it's good to know, 12 seconds, 10 seconds prior to what you're seeing, and when you can push the button, the kiddo is actually still already having a seizure. So I like that you explained having the parents there, and it's important. Parents always ask us, well, why do we have to be there? Why do we have to stay the entire visit if it's a longer stay? And really, it's just to notate, number one, they're the expert on the child, and number two, it's as much of an education for the family on what's going on as it is to see the child's seizure.
Yeah, and again, going back to the earlier discussion, they are the ones who are seeing the staring episodes at home. If it's a non-epileptic, if it's a non-seizure staring episode, I may not pay attention to it during the video EEG because I watch the EEG and nothing is happening. But the parent may say, but he's staring. Then I could say, yeah, okay, so you're worried about that one? That's not a seizure. He's just staring. He's just being an adolescent. He's just not paying attention. But that's not a seizure. Oh, that one he's staring, that was a seizure. Let's look at the difference between the two so I could educate you. When he's staring and doing this, that's a seizure. When he's staring and he's not doing this, then he's just staring and not paying attention to you. So it's a learning experience, not only due to the fact that what you mentioned, most of the time parents would say they press the button and it's towards the end, and I go in there and I say, I know you pressed the button, but seizure has been happening almost a minute before you actually saw it. So other parents say, will I miss anything? Well, you're not going to miss anything. You may miss something, but the EEG is recording 24/7, and we review the whole thing, and we may see a seizure when you're asleep or when your child is asleep. And you may not see anything even when you're watching that kid. So it's a good study to try to get a density, a call density, and the actual number of seizures. Is he having more seizures than what I could see? Video EEG, let's do it.
Can you explain a little bit more in depth, Dr. Santos, on as a team and as an epileptologist, what it looks like for you when you're having to make a decision based off of EEG, based on other testings and kind of clinical findings on how we as a team now consider maybe a candidate for surgery, epilepsy surgery. Can you kind of explain a little bit, maybe the conversation you would have with the family and what that would look like?
Okay, so this is what I do. So I always tell the parents, I think your child is having whatever seizure type, right? And we need to start him on medication, this medicine, because it's a medication that's going to work well for that type of seizure. Excuse me. And the side effects are this. So why am I choosing this one? Because I think it's the one with the least side effect. And then I tell parents, I could, with the first seizure medication, if I choose the right one based on the type of seizure, I could make that child seizure free, let's say 49%. If I max it out, push it to the limit and you didn't have any side effect, that medicine should work 49% of the time. If you fail the first one and you go to a second one, the second medication works maybe 10, 14% of the time. So you see the numbers drop, right? From 49 to 13 to 14. If the second medication fails, you used it, this is predicated on that you used it appropriately, you used the right amount, and they're not having any side effects, so you pushed it to the limit. The third medication is only going to work less than 5% of the time. Okay, so if you look at that pie, if you keep the number tab, we could make patients seizure free about 65% of the time with 1, 2, or 3 medicines. So which takes us, and I tell them that. So if your child is failing 2 medications or tried adequately, pushed to the max, no side effect, you really need to see, as far as I'm concerned, you need to see an expert who could talk to you about epilepsy surgery. Now, one thing to remember is when you go see an epileptologist to talk about epilepsy surgery, they're not going to do epilepsy surgery right away. They're going to do more studies to see whether your child is an epilepsy surgery candidate or not. So you have to do those tests before you could say, yes, your child is a surgical candidate. No, your child is not. And that's when you could open the discussion. Okay, what kind of surgery are we talking about? What's the chances? What's the complications? What's the chance of my child becoming seizure free with the surgery? Is he going to be able to come off medication eventually? You're not going to know those answers if you don't go through the test. And the earlier the better, because it's really hard to sort out the effect of the seizure and the effect of the medication, unless you could take one out, right? I could tell you, for example, okay, I'm not going to name names, but I think someone will recognize this, right? If the kid has had seizures since age 5 months, and we got them at 13, the kid's functioning was so low, but we were able to make that child seizure free and has been seizure free 3 years earlier this month. That kid's mentation doubled in 6 months. Okay, we have more of those information. We have kids who are they say, okay, they're doing well in school, yes, because they're so smart. But when we do the test before surgery and we do the test 6 months after surgery, we still see significant improvement in their function because we made them seizure free. And so when you're, again, I'm going to reiterate this, if your child is failing 2 or more medications, you need to talk to someone who could advise you on whether that kid is a surgical candidate or not and go through testing. And like I said, going through through testing does not mean you're going to go do the surgery. So don't be scared. It's just a process. Then you could ask appropriate questions when the tests are done. Otherwise, you won't know.
So for those people who may be watching this, not from Valley Children's in the future, what I hear you say is if their child's on 2 or more medications and it has not been adequately controlling their seizures, to make sure that they get a referral to see specifically an epileptologist.
Yes.
Not, to even have a conversation about the possibility of what surgery may look like. Don't hesitate to have the conversation.
No,
because
I mean,
the longer you hesitate,
it's really just a conversation.
Yep.
It's not a surgery. Yes, we're talking about surgery, but it's a pre-surgical look. And if you don't go through that, you're not going to know whether you're a surgical candidate or not. Now, not everyone who comes and say, am I a surgical candidate, are actually surgical candidate. Right from the start, we also know that there are a lot of people who go through the pre-surgical workup and at the end of the day are not good surgical candidates, but there are other surgical options. And we do all of them here. The key takeaway there is if your child is still having seizure after 2 medications, you need to think about epilepsy surgery. The sooner the better, because the long-term effect of seizure may be there even after they are seizure-free. The other thing to remember is they may start having seizures on one side, but after years of having seizures, the other side may actually get involved. And by that time, it will be too late. We cannot do surgeries on both sides, obviously. So the earlier, the better. When the psychological effect of having seizure is not permanent, that will be a perfect time.
Perfect. I think that's wonderful, Dr. Santos. I think, just making sure that families understand really that nothing hurts by having a conversation. Don't be scared to reach out. Don't be scared to ask the questions. No question's a silly question. That's what our doctors are here for, especially your epileptologists. They're there to answer the in-depth questions that, will help you make a decision that's, going to be better the sooner that you make it to see your doctor. So don't hesitate, don't wait. I think that's the most important key to take away from this. And, there's a whole team of people who care about your children and who care about controlling seizures as much as possible. And that's really what our team does here. And it's truly a team approach. You as a parent are part of the team.
Yes.
And so I stress that to a lot of our families. Make sure that you have those conversations. You are an expert in your child's care. And we really promote that at Valley Children's. Our doctors do a wonderful job, especially Dr. Santos, with advocating for our families and for our children to have a voice and to continue to talk about this and continue to educate and continue to advocate. So Dr. Santos, I really appreciate you taking the time to have this conversation with us. And again, if you guys want to share this, hi, if you want to share this with anybody, it will be on the epilepsyawareness.org website for the next year until we do this again next year. So thank you so much for being here. We have one more, looks like one more conversation a little bit later this afternoon in Spanish. So those of you who speak Spanish or know anyone who would like to have a conversation in Spanish, please feel free to join. And that one will be at 4 p.m. today. So does anyone have any questions before we wrap up this session?
I'm so bad with questions. I swear. So bad.
But there's no such thing as a stupid question.
No stupid questions.
Yeah, I know.
Trust me, because I ask the same ones over and over again. So
no, people ask me questions all the time. I never call them stupid. Nope.
Sometimes people just need to hear it asked a different way, right? I mean,
Yep.
You could be presenting the same information, but if it's presented a different way, it's easier for people's brains to process that differently. So
yeah, and if you don't ask question, then you're not going to know the answer.
And honestly, we talk about this all the time. We would rather you ask us questions than Wikipedia anything. So please.
Yeah, and if I don't
Yeah,
know, I'll
I
tell you I
know.
don't know the answer.
I know. And I always look up questions too. That's why I'm trying to think, what do I look up? I forget.
Yeah, you could look up question, but my thing there is
I'd rather ask you.
yeah, don't believe everything you see or read on media,
Oh yeah.
because those are different cases all the time. May not be completely the same as
life.
what you're dealing with.
And everybody's case you guys treat independently. So that's the
Yes.
most important part, is that we have a general overview that we give for families, but each family is at Valley Children's handled with specific care for that child with what this child needs. And so our doctors do a wonderful job in teasing those parts out for each family. And it looks like one person had mentioned encouraging patients to get a second opinion.
Yes,
Absolutely.
I was just going to
Absolutely.
mention something. Absolutely. Okay, so if I am treating your child, one, you're not happy, one, we're using the right drug, and I don't seem to make any dent on seizure frequency, I'll be the first to ask you, would you like to see someone else? But I could tell you, I'm not offended when people ask me, Dr. Santos, can I get a second opinion? I said, yes, definitely. Yes, get a second opinion. If you're not happy, if your questions are not being answered, that's your right. Get a second opinion. You may go
And
back
don't
to
feel
the other
bad.
one.
Don't feel bad as a parent asking for that. I think that people are embarrassed sometimes. They don't want to hurt anyone's feelings. And it's really has nothing to do with not liking a particular provider, not liking anything specific, but being able to advocate for yourself and your family, right? And saying, hey, I just want more information, and more information oftentimes, will come from different people. And so absolutely, don't be afraid to ask that.
Yeah, and it's actually very, to me, I take it, I would rather you tell me or ask me, Dr. Santos, can I get a second opinion, than go get the second opinion without telling me, and then I hit it the back way. And so just say, I just wanted to get the second opinion. No, please, go ahead. And then, so if you went to the second opinion and you hear the same thing, and you really wanted to go back to your regional neurologist, then you didn't burn any bridges. You see, you still get a good physician-patient or physician-parent-patient relationship. So it's okay to ask for a second opinion. There's nothing wrong with that. Thanks for that, Angelica. And the top family, you're welcome.
Well, thank you everyone for being here. This was really, really good information, Dr. Santos. I think it directed people in the right direction and gives us a better idea of where to even start, what questions to ask, how to follow up. And I think that that's really helpful, especially for people who aren't familiar with the process. So thank you for taking the time to do this. And
Oh, you're welcome.
Really appreciate it. Really
Anytime.
appreciate it. So everyone come back here at 4.
Yes,
If you speak Spanish, mi muy poquito. So we'll see how this goes.
Bye.
Bye.
Dr. Santos.
How are you?
Bye.
See you, Jessica.
Bye.
See you, Barbie, and bye. Thank you, guys.
Everybody have a good rest of your day.
Thank you.
Bye.
Where'd the button go? I can't leave. There it is.